Hi everyone. Now we are going to discuss about complication of dialysis. First of all, introduction of dialysis complication. Hemodialysis is a life-saving renal replacement therapy used to remove waste products, excess fluid and toxins from the patient. In patients with kidney failure, although it is effectively treatment of end-stage kidney disease and it is an acute kidney injury, it associated with several complications that may occur during after the dialysis section. These complications can be acute, such as hypertension, muscle cramps, nausea, vomiting, dialysis disequilibrium syndrome, air embolism, hemolysis, and the allergic reactions, or chronic, such as infection, vascular access failure, and cardiovascular disease. These are the main complications of hemodialysis patient. Next, the complication of hemodialysis can be classified into acute and chronic. Acute is a condition during immediately after dialysis, then chronic is a long-term disease condition. Hypertension is most common complication of every dialysis patient. Then it is due to excessive fluid removal, low blood volume or cardiac dysfunction. Then the symptoms of dialysis, it's first one dizziness, nausea, sweating and fainting. Next one, this complication of hemodialysis, first one is hemolysis. Hemolysis is caused by a medical injury. It's overheated, heated dialysate, contaminated dialysate or chemical toxins. The symptoms of hemolysis is chest pain, back pain, dyspnea, dark colored blood. The another conditions like air embolism, entry of air into the blood circuit. The symptoms, one is chest pain, dyspnea, hypertension, then collapse. First, air embolism. Air embolism is a potential catastrophe and its symptoms like recurrent and dyspnea, cough, arrhythmia, chest tightness in seated position, seizures, death. The signs of the air embolism forms in venous line. It's the sounds its etiology like arterial needle and pre-pump air entry or intravertebrally opened catheter. The management of air embolism like venous line clamp, pump stop, recumbent position, then oxygen, ventricular air aspiration, resuscitation. Next, we are discussing the dialysis reactions. The first one, type A, anaphylactic type. The manifestation of dialysis reactions like mild. It's a condition spiritis, cough and sneezing, diarrhea, abdominal cramps, severe impending doom, dyspnea, feeling firm, warmth at AVF or body, then the cardiac arrest. Ethylene oxide is contaminated dialysis solution like bacteria and endotoxin symptomatic in first 2 minutes. The heparin is nasal conjunctions and anaphylaxis urticaria. Then this anaphylaxis condition, the management of dialysis reactions like bloodline clamps, HD, cardiopulmonary support and antihistamine steroids, epinephrine. The prevention of the dialysis reactions is ethylene oxide changed to gamma radiations after RO, the other causes of heparin. Next, the another condition of dialysis patients like dialysis disequilibrium syndrome. Dialysis disequilibrium syndrome is a neurological and systematic symptoms during or after nausea, vomiting, restlessness, and a headache, then seizures, coma. The etiology of dialysis disequilibrium syndromes like brain edema, CSF, then pH change. The first one, the management like mild disequilibrium symptomatic, decreasing the buffer or solute removal and avoid pH severe changes. HD discontinuation, this hemodialysis continuation is another management technique. Then severe disequilibrium HD discontinuous saline mannitol. Prevention like in acute HD URR urea reduction rate is 40% in HD. Dialysate sodium near to plasma sodium. Next, nausea vomiting. Nausea vomiting is the common complication and cause of the hemodialysis patient. Etiology and incidence like 10% UA causes in hemodialysis. The multifractional often during hypotension episodes is disequilibrium syndrome, dialysis reactions and gastroparesis. The management like hypotension management, antiemetic, metoclopramide. The preventions of hypertension avoidance. Next one, the muscle cramps. Muscle cramps is etiology like high prevalence in 1 month of HD starting hypertension. Then another condition is hypovolemic and high UF and low sodium dialysate. It induced vasoconstrictions and followed by hyperperfusion. Abnormal muscles relaxation occur. The other causes of hypercalcemia or hypomagnesemia, hyperkalemia, it's a low cardiac index, low potassium and calcium dialysate. The management first be we should saline, glucose, mannitol, nifedipine, muscle stretching. These are the management of muscle cramps first. Then the prevention method is stretching, exercise, dialysate sodium, dialysate magnesium, biotin, keratin, Ranitins, vitamin E, oxazepam. These are the medications and preventions of muscle cramps. Next one is the intradialytic hypotension. Intradialytic hypotension related to cardiac factor. The diastolic dysfunctions is a common and hypertrophy decreases the flowing, decreasing the pressure and cardiac output. It improves the and heart rate and the contractilities is mechanism dysfunctions compulsory and the dialysis solution is calcium. Dialysate calcium is 1.7 millimole versus 1.25. The detections of hypertension, it says symptoms and signs regular PP measurements of 1 hour or 30 minutes. The management of IDHS or position saline 0.9 hypotonic. The saline increases vasopressin, albumin, glucose, mannitol infusion, decreases of ultrafiltration. The decreases blood flow rate when we use acetate. The hypertension is related of lack of vasoconstrictions. In intradialytic case, hypertension is decreased total peripheral resistance TPR and the arterial pressure shifted to vein. First one, the lower dialysis solution temperature, then the avoid intradialytic food injection, then it minimizes the tissue ischemia and due to anemia and hypertension increases the adenosine during dialysis. Transfusion can be useful. The adrenaline, the midodrine and for agonist and 10 mg per given, and the antihypertensive medications and HD after HD and decreases. Next, the intradialytic hypertension related to blood volume changes can be limited with the prevention of large blood volume changes. And first, avoid the intradialytic weight gain, fluid intake limitations, then increasing weekly treatment and time frequency. Next, maintaining and increasing the urinary volume. Then we choose a target weight carefully and use appropriate dialysis solution sodium level. BP is decreasing 90 mmHg or decreasing 20 to 30 mmHg during HD. Then the another point is the distressing symptoms and poor outcome is common in patients with the pre-dialysis low blood pressure. Then the mechanism, intradialytic hypertension related to blood volume changes, hypertension related to the lack of vasoconstrictions, the hypertension related cardiac factors. Thank you.